Good afternoon, everyone. I'm very glad to see you all here in this wonderful city, Antalya. And I'm very glad to share this podium with my wonderful colleagues. And I would like to thank all the participants who competed with me in MegaMind. And lastly, and not the least, I would like to thank MegaGen and MINEC for organizing this wonderful event. Today, what I'm going to talk about is the relationship between the fixture thread depth and the placement accuracy during the fully guided immediate implant placement. I'm a board-certified periodontist in South Korea, which is a home country. Yeah, there we go. This is me, and I'm from South Korea, and the country of MegaGen. And currently, I'm working as a clinical full-time faculty in Yonsei University College of Dentistry. So what we do during the implant placement in the extraction socket, we used to modify the path during the drilling as well as during the installation. And the reason is, this is because to optimize the accuracy. Most of us would say this is not a difficult process, but I can definitely tell it is not easy. And sometimes for me, honestly, it is quite stressful. But now we have this digital dentistry-based, fully guided implant surgery, which allows to us place the implant as accurate as possible based on what we planned before. And we do all know the benefits that fully guided surgery gives to us. However, I would like to ask, do we always get these benefits? Well, I would say no. Especially when we are placing the implant in the extraction socket immediately after the extraction. So this research tells us why we need to be more cautious in certain circumstances. And in this research, we investigated 187 implants placed by fully guided surgery. And what we saw was the placement accuracy. And we also conducted regression analysis to find out whether there's any kinds of significant factors which affected placement inaccuracy. We collected all the digital data from the patient, which was pre-surgical as well as post-surgical, and we superimposed these two data. So based on the superimposition, we figured out how much deviation has occurred after the surgery. So let's take a look at outcomes. In linear, the mean deviation was less than 2 millimeters. And in angular, mean deviation was less than 4 degrees. And these numbers were very similar to what we learned from the previous studies. And what we further did, and which is more important, was this regression analysis. And we included a bunch of factors that we could include. And among these factors, what we could conclude was positional inaccuracy may increase when the implant is placed in the site having uneven bone density, or if we use mucosa-supported guide, or if the implant position is far and more distant from the adjacent natural tooth. And today I'm going to focus on the first factor. So, mostly we face uneven bone density in the mandible rather than the maxilla because the upper bone is mostly composed of cancellous bone, while the lower jaw, usually cancellous bone is surrounded by hard and dense cortical bone. So let's say we are placing the implant in the mandible, and in the mandible, the fixture will pass the soft cancellous bone part first, and then the apex of the fixture would meet the hard cortical part, and this kind of slipping movement may happen, which may eventually cause this kind of buccal dislocation. And very similar thing can happen during the immediate implant placement, since the fixture, especially the apex of the fixture, first meets the hard and dense the cortical lining of the bundle bone, which causes this kind of dislocation, ending up placed in the middle of the socket. So that's why we do this kind of compensating movement during the surgery, especially during the freehand surgery. And not only just we do these kind of motion, we can also have the tactile sense during the surgery. How we can feel how the fixture is getting into the osteotomy site. And if we feel something wrong, we can fix the path and we can fix the position. However, when we fully depend on this surgical guide, this interface between the surgical stand and the drill, or between the surgical stand and fixture mount, blocks the compensating motion and tactile sense that we can have. So, since these two important factors are blocked, I would like to say the fixture design and fixture type can be a very crucial factor that we should control during the surgery. And indeed, we do know that between these two types of fixture, one with the cylinder type having without any kinds of self-tapping structure, the other one, conical design, having a self-tapping structure at the apical, this one is better in terms of placing accurately. And always, the diameter of the implant fixture is wider than the final drill diameter. We always install the fixture which is wider than the osteotomy site. And in case of immediate implant placement, the osteotomy site locates along the slope of the wall. So when we do the osteotomy and when we place the implant, we always feel this kind of resistance. And if the resistance gets bigger, there is more chance to be pushed away from the wall. So I could easily assume that between these two threads, shallower one would have a less resistance, and I could assume that shallower thread would have a less chance to be pushed away from the socket wall. However, this assumption that I made is very roughly made, and it was not supported by any kinds of scientific evidence. So what I wanted to do is research about it. So in this in vitro human cadaver study, we recruited human cadaver jaw, and what we saw was the accuracy of guided immediate implant surgery, as well as the influence of the fixture thread depth in the placement accuracy. So as I said, we collected these jaws from the Department of Anatomy, and among the teeth that I can pull out, we only decided to pull out single-rooted tooth, which were incisors, canines, and single-rooted premolars. And in case of incisors and canines, I plan to place the implant along the palatal wall, which we usually do in the clinic. And for the premolars, I plan to place the implant in the middle of the socket. Based on the surgical stand which is printed, after the extraction, I place the implant very passively. And these two types of the fixtures were directly compared, which were MegaMind blue diamond regular threads and deep threads. As I said before, we collected all the digital data and superimposed, and based on superimposition, this time as well, we figured out how much deviation has occurred. So, results. In case of planning to place the implant in the middle of the socket, there was no difference between the regular threads and deep threads in terms of placement accuracy. However, when we plan to place along the palatal or lingual wall, deeper ones caused a lot more, significantly more deviation compared to the regular ones. So based on these outcomes, I could tentatively conclude that in case of planning to place the implant along the socket wall, shallower ones would be beneficial. However, when we plan to place the implant in the middle of the socket, either one would be fine. But in terms of achieving better primary stability, I used to prefer the deeper ones. So based on what we learned, let's take a look at my case. This patient came to my office to extract this right mandibular first premolar, which has already been fractured. And soft tissue condition was fine, so what we planned was fully guided immediate implant surgery. And as you can see in the CBCT told me to place the implant 2 millimeters deeper than the bony walls in order to achieve sufficient amount of mucosa. And it told me I should place the implant along the lingual wall to have an ideal position, ideal design of prosthesis. So based on what we learned from the previous in vitro study, my choice was blue diamond regular threads. After the extraction, fully depending on the surgical guide, it was placed. And you can see that fixture has been perfectly placed in the lingual side. And we had this buccal dehiscence defect, so we applied particulated bone graft material and covered with resorbable membrane. And then what we did was we delivered this prefabricated customized healing abutment, which was designed and fabricated before the surgery, fully based on the virtual planning. And this delivery was very successful and passive, which means that the accuracy of the placement was very optimal. After the soft tissue healing, we delivered this prosthesis, and now this patient is being followed up right now. And so far, as the serial X-ray shows, the patient is being followed up without any kinds of complication. Next patient, very similar case. This patient wanted to pull out this right mandibular second premolar, which had very severe dental caries in the cervical area. And as you can see in the clinical photo, the crown part has been already fractured because of the caries. And this time as well, CBCT told me to place the implant 2 millimeters deeper compared to the bone crest level. And to have a nice prosthesis, I needed to place the implant in the middle of the socket. So, either regular threads, deeper threads would be fine, but my choice, as I said before, to achieve better stability, my choice was deeper thread ones. After the extraction, fully depending on the surgical guide, as you can see in the middle image, this intraoral scan image, the fixture has been perfectly placed in the middle. And this time as well, prefabricated, customized healing abutment was successfully delivered. And after the soft tissue healing, we delivered prosthesis, and this patient as well is being followed up right now. And serial X-ray tells us that this patient is using this implant so well without any kinds of complication. The bone level kept fine. Okay, so what we are doing right now is we wanted to translate the outcome we had from the previous in vitro study to the clinical stage. So in order to do that, we designed this randomized clinical trial comparing these 3 different types of fixtures. And I really hope that we could share the value of outcome with a nice publication in the near future. So it's time to wrap up. And I would like to summarize what I discussed today. Firstly, in case of fully immediate guided implant surgery, we need to be more cautious in order to minimize the inaccuracy, because there is always the interface between the surgical template and the drill, which blocks very critical factors, the surgeon's visual and tactile sense that we can have. So, fixture design, or we can say fixture thread depth, could be a very critical factor that we need to control during the surgery. So my suggestion, based on the previous studies that we did and based on my clinical cases, I would like to suggest when we plan to place the fixture along the socket wall, I would like to suggest using shallower ones, which could be represented by MegaMind blue diamond regular threads. And in case of planning to place the fixture in the middle of the socket, either one could be fine, but as I said, I like having better stability, so my preference is deeper ones. For example, MegaMind blue diamond deep threads. This is all I have for you today. I'm sorry for the things happened during the presentation, but anyway, thank you very much for your attention.